Chapter 3, Lecture 3. Economic analysis techniques. In the previous lectures, you learned about the cost analysis and cost-benefit analysis. For cost analysis, we don't compare the benefits and outcomes of the projects. And for cost-benefit analysis, the limitation is that you compare both cost and benefit in terms of monetary values, which is sometimes is not ethical to put money values for human life. So therefore, we need another economic evaluation, such as cost effectiveness analysis, which includes both costs and outcomes. Of course, costs expressed in dollar terms and outcomes expressed in unit of one health outcomes. So you have to carefully choose that your health outcomes. So the effectiveness measure should clearly reflect the project objectives. So it is important to choose the right outcomes measure because the results are sensitive to this choice of the health outcomes you're choosing. For example, if the objective of the project is to decrease the teen pregnancy rate, therefore, your intervention is, for example, types of educational, education in health for teen pregnancy. Your outcome could be repeat teen pregnancy averted, can actually basically determine the benefit, the effectiveness of this educational program, for example. If you choose another outcome, maybe that cannot evaluate the effectiveness of this project very well. So the cost effectiveness analysis includes both costs and outcomes. Of course, outcomes when we wanted to evaluate, we look at the outcomes per dollar of cost. So for example, repeat teen pregnancy averted per dollar spent on family planning programs. So you wanted to maximize the outcomes per dollars, or you can actually evaluate the cost per unit of outcomes. So cost per repeat teen pregnancy averted, you want the lowest cost per outcomes, right? You can say that the cost of one averted teen pregnancy, for example, is $1,000, or you can say that you can actually, in terms of outcomes per dollar of cost, you can say that one averted pregnancy, teen pregnancy averted per $1,000. So you can say in both ways, basically. Now, the incremental cost effectiveness ratio means that incremental means that additional. So incremental cost effectiveness ratio is additional cost effectiveness ratio. So you are comparing the new medical treatment or procedures or services, the new one versus the old one. The cost of new treatment we show by cost of new, C new, and the cost of existing treatment is the cost of old or C old. And medical effectiveness of the new treatment is the E new, and medical effectiveness of existing treatment is E old. So the incremental cost effectiveness ratio usually is called IZER, which is equal to the ratio of the differences between the cost of new and old treatment over the effectiveness of the new and old treatment. So this IZER ratio tells us if this ratio is actually cost effective for new treatment versus the old treatment. So now, there are 4 cases. 2 cases out of 4 cases are clearly we can make a decision. For example, in the first case, when the new treatment dominates the old one, is when the new treatment is less costly than the old one and is more effective. So clearly here there is no hesitation that we can approve the new treatment versus the old one and choose the new treatment because it's less costly and more effective. In the second scenario, the old treatment dominates the new treatment when the new treatment is more costly and less effective. So there is no hesitation here that we reject the new treatment versus the old one because the new treatment is more costly and less effective. There is no hesitation to reject the new treatment. If we wanted to show these 4 cases in the cost effectiveness plane, that you may see this in any pharmaceutical company's article, if you pay attention, it's actually very interesting to learn that and to see how it works. In the vertical axis, we have the basically the cost, net cost. And then in the horizontal axis, we have the effectiveness. So as we go from left to right, the effectiveness is larger. And as we go from bottom to top, the cost is increasing. So this is called the cost effectiveness plane, which shows how cost effectiveness analysis can be used to determine whether we have to accept a new medical technology or reject it. As you can see that here, as we go from left to right, the new treatment enhance health or life expectancy, and to the left of the origin is diminishes basically the health compared to the current treatment or old treatment. And again, the net costs are measured on the vertical axis with the positive net cost basically scored above the origin and the negative net cost scored below the origin. So let's start from quadrant 1. This is the quadrant 1, and we say that the situation is when the new treatment is more costly and more effective, right? This makes a little bit difficult to make a choice between the new treatment and the old treatment because depends on how much is more costly and how much is more effective. So we need actually a threshold here to tell us how much basically more costly is acceptable than new drug. Usually $50,000 basically per patient per year is acceptable, and we talk about that. This is questionable and depends on how much is more costly and how much is more effective. In the quadrant 2, so we go actually counterclockwise. In quadrant 2, we have the new treatment is more costly and it is less effective. So there is no question here that we reject the new treatment versus the old one, and because the old treatment dominates in terms of both cost and effectiveness, and there is no question that we reject the new treatment. In quadrant 3, we see that the new treatment is less effective and less costly. Again, this is questionable, how much is less costly and how much is less effective. Then we can actually decide based on the amount of basically effectiveness and cost compared to the old actually drug. So this is questionable, and we can decide basically based on these differences. Uh, in quadrant 4, again, we have a case that is the best case scenario. That's a new treatment is less costly and more effective. So there is no question in this scenario we accept a new treatment because in both cases of cost and effectiveness is actually preferred to the old treatment. So this is the best case scenario. And so in two cases, we don't have any question. And in scenario, in this quadrant 2, the old treatment dominates, and quadrant 4, the new treatment dominates. So the differences between cost benefit and cost effectiveness analysis basically is that the cost benefit analysis measures both total social costs and benefits attributable to a given medical intervention in monetary values, but the cost effectiveness analysis measures the total cost of achieving a a specified healthcare objective, such as, like, say that a life years saved, or you can say that prevent, for example, averted number of teen pregnancy. So the outcomes should be selected based on the objectives of the main objectives of the project, and remember that it is very sensitive to the selected outcomes. So the advantages of all cost effectiveness analysis to the cost analysis and cost benefit analysis is looking at both costs and outcomes, and you don't have to place a dollar value on outcomes. So the differences between the cost benefit and cost effective analysis is that unlike the cost benefit analysis, cost effectiveness analysis cannot tell you whether to fund a program or not, because you have basically different health outcomes. And if you have two projects to compare, one of them is in terms of, say that, averted number of the teen pregnancy, and the other one is in terms of lowering cholesterol level, how you may be able to decide between these two projects. That makes difficult. For example, suppose it costs $5,000 to avert each repeat teen pregnancy. So the program planner must decide whether this program is worth funding compared to the, for example, a smoking cessation, which is basically decreasing the number of the smokers. So outcome measure selected is inherently arbitrary. So you have to basically be careful of what is the right outcomes you have to choose. And definitely it's difficult to compare different projects with different outcomes. If you have a limited budget and you have to choose between different projects with different outcomes, there is no way you can actually make a selection. So that's the limitation. So therefore, economists came with another economic evaluation by creating a unit index in terms of cost utility analysis. So the cost utility analysis considers both quality of life and number of the life years saved. So basically this utility analysis is adjusting the number of the life years gained by some types of indexes that reflects the health status or quality of life. So it is called quality adjusted life years because it's taking into account both quantity and quality of life. So it's multiplying the life expectancy multiplied by health index, utility index. What does it mean? Means that when they are surveying the patients, they survey the patient at the baseline and they give the scale of 0 to, for example, 1, and they say that, okay, from 0 for the status of death and 1 for the 1 year of full health, tell us what is the current condition of your health. So if the patient, for example, suffers from back pain and is really in pain, the patient may actually say that I rate my current health condition at 2 because I'm in pain. And if the patient is in, like for example, young age, it's 20 years age, so the surgeon telling to the patient, okay, you're 20, you have 20 years basically, and you're in 20 years, and you have at least 60, basically say that 60, 70 years of life to go. Do you prefer to live in for 60, 70 years of life with this pain, with the status of 2 out of 10, out of say that 0.2 out of 1 in your life, and the patient. So remember that this scale could be 0 to 1 or 0 to 10, doesn't matter. The point here is that when the patient with back pain says that between 0 to 1, I rate my health status as 0.2, means that that patient is really in pain and doesn't have a good quality of life. So if the patient is young, then the surgeon says that there is a surgery but there is a 50-50 chance of success or failure in this surgery. So if the surgery was successful, therefore you may actually live with the health of almost perfect health for the rest of your life, say that 0.9 basically. And if it was the surgery was basically failed, then you may actually lose even basically walking on your feet again, or you may actually die even. So if the patient is risk taker and is young, definitely with the condition of 0.2 may take the surgery to have a perfect health, because who wants to live in the health status of 0.2 for 60, 70 years actually. But if the patient is old, say that the patient is 70 years, 80 years old, and the patient has the quality of health of 0.2, the patient may not take the surgery because it doesn't actually really worth taking the risk of not being able to walk. So here the survey is taking the time trade-off between the present and future value of the health status, taking into account the risk and also the time of the life expectancy. So the cost utility ratio from a new medical treatment of technology is called quality adjusted life years, many agree that if the cost of new medical treatment is less than $50,000 per additional year of life saved, it is generally viewed as favorably. So, um, so if the cost of new treatment minus the cost of old treatment over the number of the qualities of quality adjusted life years, so is if at the top we have $50,000 over the differences between these two is one, then in most of the countries they say that the new treatment is accepted if it costs less than or equal to the $50,000 per quality adjusted life years. And this $50,000 history goes back to the time basically keeping alive a patient with kidney disease alive. It costs actually $50,000 per year. So it's not ethical to refuse to keep a patient with kidney problem alive. So therefore, they actually set this as a threshold for basically a cutoff point for paying per patient to live 1 year based on that actually patient with kidney problem. Now, the critics of the cost utility analysis is that it is very complicated index. Nobody basically can understand what it is. Nobody means that those people, they are not very technical people. So the discrimination based on the, of course, if the person is young or old, is another critique for this type of economic evaluation. It doesn't tell us whether the overall well-being of society is increased, because this is basically quality adjusted life per patient per year. And it shows on just whether one medical treatment or technology is more cost effective than another one. So for one patient doesn't tell us the whole about the whether the society well-being is improved or not. Now we are done with chapter 3, lecture 4.